Hello. Thank you for joining us at the CHCI Health Summit and our plenary session, Addressing Social Determinants of Health in Latino Children, Youth, and Families. My name is Lupe de la Cruz, Senior Director of Government Affairs for PepsiCo. I am also pleased to serve as the CHCI Board Treasurer. I have served on the CHCI Board of Directors since 2015. Through ongoing support from the PepsiCo Foundation since 2014, PepsiCo has sponsored a class of health graduate and policy fellows each year. On behalf of CHCI, I would like to thank Novo Nordisk, Casey Family Programs, American Cancer Society, Fresenius, and the Blue Cross Blue Shield Association for their generous support of this session. Without the support of organizations like these, the important work of CHCI might not be possible. Health disparities in underserved Latino communities affect the well-being of children, youth, and families nationwide. During today's plenary session, you will hear from experts tackling issues affecting social determinants of health and discuss promising programs and ways of leveraging technology to address health disparities. As your MC this afternoon, I have the distinct privilege to introduce our panel host, Congresswoman Nanette Diaz-Barragan, Lisa Lacasse from the American Cancer Society Cancer Action Network, and our moderator, Rafael Lopez. Our panel host, Congresswoman Nanette Diaz-Barragan, became the first Latina to ever represent California's 44th Congressional District in 2016. She is the second vice chair of the Congressional Hispanic Caucus and a member of the Progressive Caucus. She serves on the House Committee on Homeland Security and was appointed to the Exclusive Health Committee on Energy and Commerce. To address the social factors that drive health disparities, in April of this year, Congresswoman Barragan announced the Improving Social Determinants of Health Act of 2020. Next, you will hear welcome remarks from Lisa Lacasse, President of the American Cancer Society Cancer Action Network. Since joining the organization in 2007, Lisa has been integrally involved in helping to establish a nationwide public health advocacy organization that influences and shapes public policy at all levels of government. We are honored to have our moderator, Rafael Lopez, founder and president of Lopez Consulting. Rafael has dedicated his career to improving the lives of children, youth, and families. He served as the commissioner of the Administration on Children, Youth, and Families at the U.S. Department of Health and Human Services, a role to which he was nominated by President Obama and confirmed by the U.S. Senate. As commissioner, he also served as the acting associate commissioner of the United States Children's Bureau and acting associate commissioner for the Family and Youth Services Bureau. Immediately prior to his confirmation, Lopez served as a senior policy advisor at the White House Office of Science and Technology Policy and with the Domestic Policy Council. I hope you enjoy this afternoon's important and timely discussion. You can continue the conversation on social media using hashtag CHCI Summit. Now please welcome Congresswoman Nanette Diaz-Barragan.
Thanks for joining this panel on the social determinants of health in Latino children, youth, and families. I'm Congresswoman Nanette Diaz-Barragan, and I'm proud to represent California's 44th Congressional District, a vibrant and diverse community that is 70% Latino. In the Congressional Hispanic Caucus, we know Latino issues are the same issues others care about: healthcare, the economy, and the environment. Pre-pandemic, Latino communities were already facing health disparities. We know Latinos have higher rates of diseases like asthma, diabetes, and heart disease compared to other communities. Social factors like housing, employment, food security, environmental safety, and educational opportunity all play a critical role in determining an individual's health and well-being. Since the COVID-19 pandemic, these existing disparities have been glaring. Latinos have had higher rates of COVID-19, more hospitalizations, and have been more likely to die of COVID than any other community. We cannot go back to a pre-pandemic normal. Normal was making people in our community sick. We need to tackle these issues from the ground up by addressing the social determinants of health. That's why I introduced the Improving Social Determinants of Health Act, which will provide funds to the CDC to focus specifically on the social factors that influence health disparities. Understanding the underlying reasons for these disparities is the first step toward improving the health of the Latino community. I hope today's discussion is also a good starting point.
Good afternoon. I'm thrilled to participate in this year's Congressional Hispanic Caucus Institute's Health Summit, focusing on the critical issues of addressing social determinants of health in Latino children, youth, and families. My name is Lisa Lacasse, and I serve as president of the American Cancer Society Cancer Action Network, a nationwide grassroots advocacy organization working to reduce the cancer burden for everyone. As it will be extensively discussed during this summit, we know that a person's health is largely influenced by where they live, work, and play. Unfortunately, the data show where you live can actually determine if you live. We all know this must change. Social determinants of health are a driving cause of health disparities experienced by far too many Hispanic children, youth, and their families. We know if a community doesn't have equitable access to education, economic resources such as affordable housing, transportation, food security, and importantly, quality health care, families in these communities have worse health outcomes as compared to other populations. So to achieve health equity, we must address social determinants of health. This is of critical importance in many Hispanic communities who tend to experience a tremendous burden of preventable disease, which includes many cancers. Cancer is the leading cause of death among Hispanics in the United States. ACSCAN believes everyone should have a just and fair opportunity to prevent, find, treat, and survive cancer, regardless of their income, race and ethnicity, sexual orientation, gender identity, disability status, or where you live. And ACSCAN is doing just that. We advocate at every level of government for increased access to cancer screenings and therapies, including making sure culturally appropriate language services and patient navigators are readily available. We've worked hard to support expanding access to comprehensive healthcare coverage, including through Medicaid, which directly benefits all people, but particularly those of lower socioeconomic status. We know through deliberate public policy change, we can improve the health and livelihood of every Hispanic child and family nationwide. I'm really looking forward to this important discussion, both today and in the days ahead. And ACSCAN will continue to partner with Congressional Hispanic Caucus to have an impact on these very important issues. Thanks so much for having me.
Good afternoon. My name is Rafael Lopez, president of Lopez Consulting and former commissioner of the Administration on Children, Youth, and Families in the Obama administration. I'm pleased to be here today as the moderator, helping lead this important discussion addressing social determinants of health in Latino children, youth, and families. First, I would like to thank Congresswoman Nanette Barragan and Lisa Lacasse for their insightful remarks and helping set the tone for our conversation. And thank you to CHCI for hosting this critical discussion on health issues facing our nation. We know that when we invest in Latino children, youth, and families, we invest in the future of the United States of America. We want to hear from you, our audience, so please place your comments and questions in chat. You can also continue the conversation on social media using hashtag CHCI Summit. I'm delighted to be joined today by 4 subject matter experts, leaders in our country, in different parts of our country. First, we will be joined by Dr. Kelly Tice-Wells, Senior Medical Director in Medical Affairs with Florida Blue. Next, we'll be joined. Nice to see you, Dr. Wells. We'll be joined by Dr. America Bracho, Executive Director of Latino Health Access.
Hello.
Hi.
Nice to be here.
Thanks for joining us. We'll also be joined by Dr. Dugan Maddox, Vice President for Kidney Disease Initiatives with Fresenius. Welcome.
Hi, thank you for including me.
Absolutely. And we will also be joined by the Reverend Danny Cortez, Executive Vice President and Chief of Staff with Esperanza.
Hola.
Welcome. So, for those of you who are interested, these four extraordinary leaders have extensive backgrounds. I would like to refer you all to their more extensive bios on chci.org, where you can learn more about each of them. And now I'd like to welcome all of our panelists back to join us for a more in-depth conversation. So one of the things about social determinants of health is that so many people have lots of different perspectives about what this means. And ultimately, I'd like to begin with the question about what do we really mean by social determinants of health and how does it affect health outcomes? And I'd like to first start this conversation with Dr. America Bracho. Would you help us kick this conversation off?
Sure. Thank you so much for the opportunity.
Certainly.
When we talk about social determinants and how they impact health outcomes and life in general, what we are talking is about the circumstances, the context of the life of people, the circumstances of their life. We can see it more clear when we think in the place where we learn, where we grow, where we play and pray, how this place can make you healthy or sick. And many times it's sick by design. So I was thinking, how do we see this play out? We have a diabetes program in my organization, and we teach people how to manage their diabetes, and we do a lot of other things that I will discuss later. But when people come to us to learn about diabetes, we also learn that we are teaching them how to eat better when they don't have access to fresh food and vegetables. And we ask them to exercise when they live in the streets that have poor lighting, that are unsafe. And we ask kids to exercise in places that do not have parks. So as we think, we make recommendations about how to eat better. And so it happens that maybe this family doesn't have a place to live, or they live in an apartment with other families and they don't even have the opportunity to cook. So it gets complicated then with literacy, and it gets even more complicated with access to healthcare and medications. But then you find out that the city where they live put more priority in budgeting for bars than parks. So there is a myriad of issues that have to do with, lack of access to healthcare and education and low wages, and all of that will influence the health outcomes for those individuals, and their risk will be higher and their opportunities to prevent will be lower. This is exactly what we are seeing right now with COVID. It's not because we are Latinos that COVID is affecting us more. It's not a genetic thing. It's that COVID required preventive behaviors that are almost impossible for many of our families. Like, isolate in your house. How do you isolate if you live with multiple generations or you have to share a 2-bedroom apartment with 5 families? Stay home working. How can you stay home if you don't have savings? If you work and you make low wages, how do you do that? And how do you connect with telemedicine when you don't have technology or broadband in your neighborhood? And how do you stay and you keep the distance, and how do you stay home? So this is a luxury. And the University of Irvine actually did a study here in Orange County where they demonstrated that the vast majority of patients in their hospital that are Latinos, they were low income individuals with large households that didn't have college, that didn't have health insurance. And again, that adds up. So just to finalize my context on social determinants is to mention that everything is connected, that we need to think in comprehensive solutions that are short-term, mid-term, and long-term. And just by providing insulin or medications will not solve the issue of diabetes. And just by providing masks will not solve the problem of COVID in our community either.
Wonderful, thank you. And now we'll turn to Dr. Maddox.
Well, I agree with everything that Dr. Bracho just said. I think social determinants of health are related to where people live and work and eat and play. And so all of those things impact health, chronic health risk, acute, but also chronic health risk and health outcomes and health-related quality of life. So I'm a nephrologist, and so I care for people who have chronic kidney disease. And I work at Fresenius Medical Care in the medical office, where we're providing and supporting teams that serve people who have chronic kidney disease. And I think, and we'll talk about it during this course of this call, I think that chronic kidney disease is really a poster child for how chronic health conditions and social determinants of health are just tightly interrelated. And that would include chronic conditions like diabetes and high blood pressure, and that we have to address issues of where people live, work, play, eat, and have access to those kinds of stable environments in order to change their health outcomes with a disease like chronic kidney disease.
Thank you, Dr. Maddox. I'd like to turn over to Dr. Tice Wells. From your perspective, what are you thinking about here?
Yes, thanks. So I'm a family physician, and I can tell you I spent most of my career providing primary care services in county health departments and federally qualified health centers, and became really proficient at identifying and managing those patients who were dealing with barriers to adhering to whatever treatment regimen or protocols I would put in place. And we all sort of knew the things that folks were up against. And I think a great term to consider rather than determinants of health is really drivers of health. If you think about the things that can either promote or worsen health outcomes, those are the things such as we've described. Now, when I came to Florida Blue, there was this opportunity for the first time to take what I'd been doing on a case-by-case, patient-by-patient basis throughout my career and really apply that on a population perspective, right? So there's this opportunity now to know, based on where our members are, where the levels of significantly high social vulnerability is. And to Dr. Bracho's point about households, we were able to track transmission in some of our member households, where at one point we saw COVID-19 move through 100% of family members that were living in a particular residence, which speaks to the ability to comply with the recommendations. Now, think about the way the health system is set up. You're diagnosed with this, here's what is required to treat it, and here, go and do these things to be sure the treatment works. And then when we see you in follow-up, we want to know how well you've complied with what it is we've recommended, right? And then, the way I was trained was you're quick to document non-compliance when a patient comes back and reports that no, they haven't been exercising and no, they haven't modified their diet, right? But we have failed to assess that they had the resources, the tools necessary to comply. And that's really what this conversation is. I think upstream of the conversation about whether or not patients have the ability to affect change in their lives based on their circumstances, we also have to think about the things that limit the choices, right? So educational attainment, that's pre-decided. And in many instances, there is this cyclical nature to the lives of our community members that really don't give them opportunity to reach any further forward, right? To try to sustain themselves, to try to build savings. And a lot of the things that would position folks to do that require advocacy and structural change in the systems that exist. And so one of the things that I found tremendous when I came to Florida Blue was the fact that when we identified these things in our members, we actually added to our team, our case management teams, and to our retail center teams, community specialists trained in social work who could identify, no matter what door a member might walk in, could identify those needs and then connect them with the service in the community that could solve it, right? And so then it does not continue to leave unmet. Those needs we know are going to be revisited, medical visit after medical visit after medical visit. And so that integration of a community specialist into our system is one of the ways we've tried to solve that, so that we can focus on kind of the care versus the barriers to care.
Fantastic. Thank you so much, Doctor. Reverend Cortez, we've heard from three different doctors, multiple perspectives, framing up this issue of where we live, work, play, pray, how all of these things affect our health, education, our housing, employment, all these different factors. And at the very end of the day, it actually boils down to community, how we build community, how we live in community. And I'm curious if you could help us all better understand what have you seen on the ground in terms of the work that you do leading an organization where you live and work, in terms of what's happening in your community that speaks to the challenges and potentially the opportunities that you're seeing as we are facing this extraordinary moment in time in history, trying to combat this virus. What are you seeing on the ground that's driving the changes in the communities that you're serving?
I appreciate the question, Rafael, in particular the way you framed it, because you speak to both the question of challenge and opportunity. And I think one of the things that we often neglect is the resilience of our communities and their ability to find ways to be responsive in the absence of systems that do not provide the appropriate response. One of the things that actually today, as we speak, the Black Doctors Consortium, COVID Consortium of the City of Philadelphia, is in our parking lot with 3 lines of 100 people each trying to get free tests associated with COVID. What is that to me? To me, that is a community response to an inability of medical systems and health systems and systems in general to respond to the need of the poor, right? So there is a resilience in our community, ability on the part of our community to come together in times of crisis to fill the vacuums that exist in our communities. Unfortunately, those responses are insufficient, right? They don't go as far as they need to. So I think the first thing that I'd like to say is that we got people in the barrios who can respond and do step up and do find ways to create the linkages and the partnerships, i.e. Black Doctors, Latino Neighborhood Agency, to provide a response to people who can't get it from other places. I think the other thing that has become apparent, and I think this has already been spoken to, is the great inability of our systems to respond to the poor. What COVID has exacerbated, it's like an epiphany, the shedding of light on just how bad the systems are when it comes to responding to the needs of the poor, right? We see unemployment, right? You lose your job, now you're gonna lose your house, or you're gonna lose your apartment, now you're gonna be on the street, you're not gonna eat well. These are the impacts of ineffective systems responding to the barrio, right? And to the people and to the poor. And the net effect of that is it's kind of a snowballing of challenges that organizations like ours at the ground level try to respond to. And we could talk more about that as the session progresses.
Absolutely. And the point that you're making, Reverend, when we think about ineffective responses, particularly around different kinds of diseases, it strikes me that particularly in the Latino community, we hear about particularly diseases that strike our community in more intense ways. So for example, Dr. Bracho opened up and talking about things that happened at disproportionate levels, for example, diabetes and how it hits the Latino community pretty hard. Or for example, Dr. Maddox mentioned a kidney disease. And I wanted to drill down in this concept of what happens when poverty ultimately gets in the picture here. And I want to ask Dr. Maddox this question about kidney disease and specifically, but really helping us understand how to help us better understand what makes chronic kidney disease part of this discussion on social determinants of health as the leading cause of health disparities in underserved Latino communities. And this ties perfectly not only with Dr. Bracho's opening comments, but thinking about Dr. Tice Wells being a family care physician, what we just heard from the Reverend talking about how we find creative, innovative responses to coming up with solutions. How do we better understand chronic kidney disease in this particular moment in terms of the crisis that we're facing as a nation?
Yeah, so thank you for the chance to talk about it. And I just want to say this is a nice panel because I think it really spans the breadth of what social determinants of health is. So, talking about all this community support, community activism, seeing the poverty and the needs of people in the community and trying to intervene. And we come from the traditional healthcare part of it. I think traditional healthcare has been very focused a lot on sick care. How do we take care of people who have, like, let's take COVID, for example, where we have acute kidney injury, people in the intensive care unit. I mean, we've got to have very robust healthcare opportunity to save lives. And we've been doing that, and that's sort of traditional healthcare. But I think where chronic kidney disease comes in, again, as sort of a surrogate for a lot of our chronic diseases that we might think about, diabetes, high blood pressure, cardiovascular disease, is that the traditional medical community has been, over the last decade, doing a lot of work to look at what impacts chronic disease health outcomes. And now we're seeing how much they're impacted by these social determinants of health or social drivers of health for sure. And so I'm just going to talk about chronic kidney disease for a minute and the way that we now know through very traditional research, health-related research, randomized controlled trials, and healthcare data, that communities and people who have food insecurity are much greater risk for having chronic kidney disease. That people with food insecurity are more likely to have progression of their chronic kidney disease to develop kidney failure and to need dialysis or kidney transplant. So we've actually seen research data that shows us that. And so we can then have better opportunity to have programs that impact that. And in fact, we know that the poorest neighborhoods and communities in the United States have the highest incidence of having protein in the urine, which is a sort of a measure of kidney injury, or of having progression of kidney disease to have to start a treatment like dialysis. So I think chronic kidney disease has given us a great look at where we're going to need to move from sick acute care to interventions that actually change the health outcomes for chronic diseases like CKD. And for example, food, and we'll maybe be able to talk about that, food is particularly important in chronic kidney disease. And I also think our research in chronic kidney disease has shown that these issues are bidirectional, that people who have poverty, who have unstable housing, who have food insecurity, who have other social stressors are more likely to develop CKD, to have CKD progression. But also having a chronic disease like CKD impacts your wealth. And so you're more likely to miss work. You're more likely to have a disability. You have greater expenses to pay for medications and healthcare, and therefore CKD is more likely to create poverty. So I think our traditional research has shown us a lot of how this chronic diseases like CKD are heavily impacted, largely impacted by social drivers of health.
Thank you, Dr.
Rafael, I would like to just add something, because I want our audience to understand, but also to be relaxed in front of the complexity of this topic. Because what we see is that this is so complex that people then go into, well, let's just help people with food. If there is food insecurity, we will find a bag of food, we'll give it to them, and that is awesome. That's great. But that is short term and it's not addressing the root causes. And because it's complex, then we say, well, let's just find healthcare for them. And that's it. And then we fragment the response, and then we don't go into what really needs to happen. And everything needs to happen. I have a friend that says, in order to help our communities, we need to do it all. And we do need to do it all. So I want just to bring that comment of Dr. Maddox to the whole housing situation. So she says people that are homeless or are in housing in poor housing situations will be more vulnerable, in terms of their kidney health. So, but housing is also an issue for kids. I mean, there are so many kids that are homeless. And then, homeless, and they live in a little room in this apartment that is also putting them at risk of COVID. And this is impacting their mental health. And this is also, many of these kids get removed and put into the foster system. But now let me tell you, how much does it take for a family in Orange County to rent a 1-bedroom apartment? If they make minimum salary, they need to work 120 hours a week in order to pay a 1-bedroom apartment. So this is how these things are connected. We might see just the chronic kidney situation, but what about the housing inequity? And I just want for people to breathe and relax, because at the end we have to come up with comprehensive strategies.
Absolutely. And Dr. Bracho, not only did you help turn the conversation in an important direction around system disruption, which not only approaching things from a systemic approach, but how important it is to actually disrupt these systems, right? I wanted to ask you to speak to one issue, which I know you work on at your organization, Latino Health Access, around the importance of training community health workers as leaders around wellness and change. Because one of the things that I know that all of you are looking at in your work about the importance of working with community, around thinking about the wellness of community writ large. And if you could speak to that for a moment, and then I'm going to follow up with Dr. Tice Wells and Reverend Cortez about 2 community pieces of work as well. If you could speak to that for a moment, please.
Right. So just to give the context on that, the real issue at the root of all of this is the lack of equity. And equity has to do with opportunities to thrive. So if you don't have equity, you are, by design, you get impacted by all of these conditions, and you have poor health outcomes and poor educational outcomes, etc. So in order to address equity, you need to bring on board the people impacted by the inequity. Because also there is a privilege in representation or misrepresentation. If at the table of the inequity, the only people sitting around are people like the ones in this panel, that is a complete table. Because people impacted by inequities are wise, have experiences, and have the right to influence their present and their future. So with that in mind, from day one, we have included the community we partner with. And watch it that I don't say that we target, because we don't target our community. This is our people. We partner with our people. And we include the people impacted by this inequity, so as community workers. And watch it. These are community workers that have salaries and health benefits, and they live in the same neighborhoods we partner with. So from day one, we brought people that had diabetes or impacted by domestic violence. I mean, they had a problem, but they were not the problem. They were the solution. So we use the problems to invite people to put the solutions at the table and be represented by themselves with their own voice. So we hire them, and they are our main team. We have 80 community workers that are paid. 40 of them are working the streets responding to COVID, and many of them are responding to emotional wellness, youth work, etc. So these are individuals that are wise, that have problems but have the solutions, and they are trusted by the community. This whole idea that people move at the speed of trust? Well, our community trusts these promotoras because these promotoras live what they live and have walked on their shoes. So we are very proud that our agency has community workers and the community at the table, informing the strategy, improving the strategy, and becoming a louder voice for justice at the end of the day.
Thank you. Dr. Tice Wells, I know that you've done a tremendous amount of work in the public health space and trying to broaden the way in which doctors address cultural competence, for example, and trying to broaden the definition of what healthcare looks like and moving beyond just disease and really thinking about wellness in a much broader space. Can you help us understand, how housing and poverty writ large interact with healthcare and how you're rethinking this from your role in a different space, connecting these dots in these last few pieces of the conversation?
Absolutely. I think that my co-panelists really have framed this perfectly, because what is necessary is collaboration, right? I think all of us in our respective places are good at a lot of things, but the failure to collaborate is what keeps us kind of addressing these things over and over and over again, right? Because we haven't connected in the right places. There are conversations that need to be had to that would help us to help our patients and members navigate the system properly, that need to be had and then acted upon, which shifts us out of dialogue and into true action. For instance, what Dr. Bracho said related to housing. The same things that influence the impacts that housing have influence the spread of public disease, of communicable illness, tuberculosis, and other things. When we talk about outbreaks and how to manage that. And so the approach really has to be, as we step into the solution, we need to solve it for the members of our communities who face the most in the way of barriers and challenges. You solve it for them first, right? Often we're making decisions based on the funding streams or how it's billed or coded or who we have good partnerships with, rather than with the right folks at the table, identifying what's the need, what's the problem that is to be solved, and then let's figure out what we need to do that. And if you shift your approach to that perspective, then what happens is, even if you don't have a comprehensive solution when you walk away from the table, you know what the gaps are. I think when we work it the other way, particularly on the corporate side of things, where we are doing it based on a finite amount of money or a particular funding stream with these particular constraints, we often meet the requirements of the grant, the funding, the process, the program, but we don't meet the needs of the person who is receiving the service. And that's really the paradigm shift we've got to make. Are we having the right conversation? Do we have the right folks around the table to participate and inform the conversation? And do we recognize at implementation what gaps we've left? And now we can direct our next activity toward closing those gaps. It really is a process.
Absolutely. And Reverend Cortez, one of the things that Dr. Tice Wells just mentioned was this importance of collaboration. And if there's anything that Esperanza is known for, is you are known for collaborating and meeting the moment with innovation and really responding with innovation. And curious about how you are thinking about, in new ways, responding in this moment to engaging young people. Right? How do you engage young people and their families in new ways when we know there are struggles to collaborate, when there are struggles around access to technology and access to the very tools of the 21st century that we know are needed to succeed, when there are a lack of resources in families, particularly around the families that you often serve in your community? Curious about how you're thinking about that in new ways.
Yeah, we at Esperanza, we run 2 middle schools, 2 elementary schools, 2 high schools, and a 2-year academic program at the college level. It's a branch campus of a university. Across that spectrum, we have about 3,000 total, quote unquote, students that we work with. One of the things that we find extremely important is hearing the voice of the youth. And understanding what it is that makes them or excites them. So, for instance, in our high school, in an effort to expose them to a variety of issues, we have majors. We have health majors, we have engineering major. We have a series of programs that allow young people to invest in and feel energetic or excited about their own educational process. We teach them entrepreneurship. We try in the extent that is possible to connect the various aspects of our organization across the space. So our housing folks provide services to our families from the high school. Our workforce programs provide services to the people in the high school. That what we endeavor to create what we at Esperanza call an opportunity community, right? A space where our definition, we don't come to health through the lens of health issues through the lens of health. We come through this question through the lens of community development. We're a community development corporation, right? And we back into issues of health because we deal with housing, because we deal with workforce, because we deal with economic development, because we deal with education across the K-16 spectrum, because we deal with immigration services, because we partner with universities and hospitals who are trying to find ways to deliver services into our community. So the way we respond to youth is taking all of that and bringing it to bear on the life of young people when possible, whether it's putting them into a program at Jefferson University that teaches them STEM education, right? And puts them on a career track that has a viable future that will give them a job that pays more than $8 an hour, which is what the average work person in the neighborhood makes at a $15,000 a year salary. So for us, we don't come to health. We look at what is it that you would want as an individual in a community? What is it you want to have? You want to have good schools. You want to have safe streets, right? You want to have access to quality healthcare. You want to have access to arts and culture. Esperanza has Esperanza Theater, where we bring the best of downtown, uptown, and we take the best of uptown, downtown. So the way we respond to our youth is to expose them to all of that, right? And by doing so, it open up a particular perspective on the world that would be very different than if they were somewhere else. It's a world of opportunity. It's a world of experience. It's a world of exposure. And that to me is about setting a new generation in the direction of possibility. So we don't do that with everybody because we got adults too that we service in a silo, right? But with the young people, it's a more comprehensive response.
Thank you. One of the issues that I want to make sure we touch on in the next few minutes before we get to questions from our audience is a complicated one, but I know impacts all of us, is this issue of how social determinants of health is also impacting the undocumented community. Because people oftentimes live in fear. And so just curious, any one of you can address this. Not all of you have to necessarily respond, but how do social determinants of health impact the undocumented community here with Latino children and families? How are you seeing it in your own work or in the organizations with which you're working?
Yeah, we see it every day in the work that we do. Individuals that are undocumented, for a variety of reasons, tend to have problems accessing services, and they are discriminated, and many times they just try not to be seen, and the system tries not to see them. So, but they are there. They are working. They are producing. So. They don't have access to healthcare in many circumstances, so they delay that appointment that will tell them what is going on. They delay, there is a missed opportunity for prevention. There are huge issues of emotional wellness. There are issues of justice in the workplace because they are paid less if they are given a job. So they sometimes they don't use the services. They don't use food stamps, which is so important to support the nutrition of our kids because they do not qualify. And sometimes they don't use services because they are afraid that if they use it, this will become a public charge in terms of immigration and adjusting their status. The reality is that when you do it right, and I think we are trying to do it right by involving people that are undocumented in the solution, of course, but when we do it right, we find ways in which people can participate and access services, and they can have a voice and activates a voice of people that actually vote, even if they don't vote. The ways in which we can support their rights, even if they don't vote in a city, where we can provide a sanctuary and many other things. So, but one of the most important steps for many of our organizations is to see in people that are undocumented their power and their voice, and not just disregard them because they don't have documents, and also to join the fight for immigration reform.
Thank you, Dr.
If I can
Bradshaw.
add,
Yeah, please.
if I can add to that, so one of the things, those of us who have done work like this in our careers, we recognize that the measure of a community really is how it cares for its most vulnerable. So the children and the elderly in particular. And that's one space where I feel like we get it wrong with undocumented members of our communities. For instance, with maternity care, often a pregnant mom who is undocumented doesn't have access to insurance coverage to cover her pregnancy. And I'm aware of a few places where we've built solutions, right? So rather than pay for traditional maternity care, maybe we create through some sort of agreement or program or process some condensed version of what maternity care might need to look like for those particular moms. And I think in terms of solutions, what we have to do as leaders and collaborators is really understand and hold ourselves to the definition of quality care, right? It's not just care, and it's not just access, right? It is the same standard of care. And so if it's important for a mom with insurance that she's paying a premium for to have monthly visits for the bulk of her pregnancy, then it is just as important for a mom who's undocumented to have access to that same level of care. And I think we don't always ensure that the care to which we are providing access really is appropriately comparable to what is available to those who aren't facing issues like that. And I just think that's an important point for us to consider, for the audience to walk away with.
Yeah,
Thank
and
you.
I might add too, just with regard to chronic kidney disease, that these are really very important issues about access to care in several respects. One is chronic kidney disease is silent. So unless you have access to care and you're receiving care, you may not even know you have chronic kidney disease and therefore have no opportunity to, do anything to try to improve your health outcomes. And particularly when you have kidney failure and you require dialysis, it's a matter of life and death having access to care. So the renal community has been very active in trying to make sure that for everyone and undocumented people, that even if we have to do it one by one because there are no good solutions from the larger federal government or whatever, that one by one we are providing this life-saving dialysis care to everyone who needs it regardless of their status. So I think the impacts are huge having this access to care. And I want to go back just a second to this collaboration idea, that it is important for us to collaborate across the whole spectrum of services to improve health outcomes. And I would say one of the things that's really changed for the kidney disease delivery system has been value-based care. I think that we see legislation and regulations change pretty slowly, but we have been a little bit encouraged in the last decade with some of the innovation projects out of Medicare to look at value-based care activity, because that at least For example, with dialysis, where for many years, because of fee-for-service and regulation, we had to just take care of people who are already on dialysis. And we as an industry had to really be separate from the providers who are caring for people pre-dialysis with chronic kidney disease. But now in value-based care scenarios, we have more and new kinds of accountable care organizations. We have better opportunity to help be involved in the care of people across the spectrum. We can partner more with nephrologists and internal medicine doctors and community healthcare centers. And we can also partner more with transportation providers and food providers and housing providers. So this kind of value-based care opportunity, which allows us to be much more holistic from a regulatory standpoint, from all the standpoints that where we can be constrained in medicine, are super important to our ability to collaborate.
Rafael, I was going to say, in the Philadelphia area, when it comes to the immigrant community, we found that the federal qualified health centers, the FQHCs, is that what you call them? Become the gateway of service to that community. They usually are much more responsive. They're connected to the ground, so to speak. In Philly, we got 3 of them: Maria de los Santos, Esperanza Health, and Congreso. And the 3 of them did an assessment on the needs of the community, both social and health. And based on that, are starting to develop programs and responses, promotoras or community health workers, and other kinds of responses that would actually be in a position to render more direct service to the immigrant community.
Fantastic.
And Rafael, I want to add that in addition to the work for the person that is sick, and here is the issue of social determinants. So this person is sick and they will go to the services for, to take care of their diabetes or their chronic kidney problem. But this person is already sick. And now we are at a point in which they need quality services. And that is super, super important. But we have to ask ourselves, why did they get sick? Why we have more Latinos with chronic kidney diseases and more diabetes? So we might provide the services, but the numbers continue to increase, and people with diabetes that are in these Latino communities continue with the complications. So in a given moment, we have to say, well, in addition to services, what else? What is really fueling this? And that we have to go to a point in which making the right decision for your health is the only decision. Right now, our communities are designed for people to get sick, and we are getting the right results because that's the design. With no time, no wage, no access to food. So our opportunities for prevention are minimal in many of our communities. So the other level is, how do we address the socioeconomic issues affecting our community so we can have communities with investments that are designed for health so people can prevent, so less people go into dialysis. So that is how we have to go and drill in the root causes of this. There are many opportunities with COVID, with diabetes. While a disease in public health, which is what I do, while a disease is impacting a lot of people, it is important. Once you get the vaccine and you got this and now it's not affecting all people, who cares about those people of color that are dying? And I'm sorry to be, a little bit into that, but I was also the director of AIDS programs in Detroit, and I have seen it. I have seen once you get to this point, who cares if the pediatric cases are among Black Americans? So the reality is that diseases are reduced to pockets of poverty once the large emergency happens. So right now, we are seeing the social determinants and how it's impacting our communities with COVID. And this is the moment to talk about housing. This is the moment to talk about the right wage for our people. This is the time to talk about justice and not just the virus. And believe me, we are talking about the mask and the virus. And we are in the streets with testing sites, but we are also talking about housing, justice, and many other topics.
Mm-hmm, mm-hmm. So I want to pick up on this these themes that you've lifted up, Dr. Bracho, and for the next few minutes, do a couple lightning rounds on these pieces and just ask you all a couple of questions. And one is asking you all to reflect on a couple of promising practices that each of you might have seen across the country or in your work in your particular areas. So we want to make sure our audience is taking away bits of optimism and hope of things that have worked. It doesn't necessarily have to be at scale, because as we know, innovation doesn't always start at scale. It starts with a promising practice either in your own organization or in your own backyard before it goes to scale. So I don't want you necessarily to feel compelled to share a promising practice that has already at scale, but something that you see that is working. And the first place I want to start is just if you can think of something that's been done in, say, the last 5 to 10 years that is changing how your community, however you define that, or wherever you live, is addressing social determinants of health. And it could be in any one thing. It could be a communicable disease. It could be from an employment perspective or an educational perspective, because each of you have touched on various elements of social determinants of health. Just choose one item, a promising practice you have seen that might help us think about something we can do moving forward, so that the audience can take a sort of a glimmer of hope, something that you want to lift up for the audience to think about. And we can start with any one of you.
Yeah, I'll jump here and give my colleagues a chance to put together an idea. One of the things that we're doing at Esperanza is trying to find a way to connect housing and wage earning in an effort to both increase the earning power of individuals, but also to provide them with stable housing, particularly in the rental market. We're finding that there's a significant population that is what you call housing burdened, which basically means that spending more of their revenue on housing, taking it away from the other necessities of life. So there's got to be a way that you can put a person into a rental situation where you can decrease their cost of rent, increase by extension their earning and saving power, and by doing those two things, stabilizing a family both economically, but also from lack of mobility, right? Which we understand has correlations to a significant number of things across the space. So at Esperanza, we are in the process of securing housing, creating financing models, which is a question of equity and investment, which would allow us to then move people in at lower rates of rent that would allow them to redirect resources to both savings and other family needs. And then we have a partnership with Jefferson University hospital system, which would come and figure out how to deliver additional services and wraparounds to those families in an effort to begin to track and see whether or not housing stability and earned income, right, the release of money to be used for other things, would have a positive correlation along with the other services that they would produce and provide. So that's one example of a promising practice in the case of Esperanza.
Fantastic. Who would like to go next?
I can go next. Yeah, in Latino Health Access, we have promotores, and I spoke about that, community workers, and we work on everything related to health, because health is not the absence of disease. So physical health, mental health, and what we call social health and advocacy. So promotores work on all of that, with a team of people that are not promotores, that, that have they are psychologists or physicians or educators. So I'm going to use an example. When people come with a problem, again, people are not the problem, for example, with diabetes, we offer diabetes education and information. Of course, that's the entrance. That's the individual health, very direct service. And we connect them with medical homes. It doesn't matter if they are documented or undocumented. But then we address the issues of obesity and healthy weight. We have gone to a point of building a park. We built a park in our community because we don't have open space. But then we went into impacting the policy of the city on open space and land use, because it's not just about not having a park. I mean, again, it's not just giving the food, but what are we going to do with the policies that are not building parks in our neighborhoods, but they fund all the bars in the neighborhood? And then we address the issues of mental health impacting our communities, all of this with promotoras. The housing issue, we created promotoras that are housing promotoras. And what they do is that they advocate for housing, they guide people, they join policies at the state of California level or the national level. And then we also work on immigration in our social area and voter activation. So we do this, we work with this definition of health, that is the well-being, that is physical, mental, and all of that is done at the community level with the community in connection with partners and with equity at the center. And we are having very good clinical outcomes as well as an increased voter registration, which is, is the idea of working at all levels.
Wonderful.
And if I could just share, yeah, I think that the promising practice really is to be sure that as you step in to solve a problem, you've looked around and assessed what your resources are. So who's doing it well? One of the strategies that we've used here is to partner even formally, if necessary, with those that are getting this work right. And one example of that is the joint venture that was created between our parent company Guidewell and Sanitas. Sanitas is a company founded in Latin America that really has a holistic kind of interdisciplinary approach to primary care services and co-locates all the necessary resources under one roof. When you're talking about taking care of members of a population who may have transportation challenges, right? You can't run them all over town to multiple resources in order to get their needs met, right? You need to co-locate services so they get the information they need in one stop. You also need to be sure that if there are social needs or other things that need to be met, that those resources are readily available as well. We've shifted, thankfully, out of this era where we hand folks a pamphlet and sort of hope that they figure it out, and really, create warm handoffs. What I love about the promotoras and community health workers is this opportunity to actually provide a sustaining, livable wage to a group of experts who already existed in our communities. And so we have used that model in multiple places because it works, right? Everybody knows the lady you go to get the answer about the thing, right? Everybody knows that. And I think what we need to do is to expand that, to be sure that we can come up with solutions that allow us to contribute to the community in a meaningful way in terms of having more folks who are employed while meeting the needs of the community. And one maybe budding example of that is to look at opportunities to pay caregivers, right? There are lots of family members who are already doing the work of caregiving, and they're absent from their jobs in doing so. And so one of the things that in one of our recent innovation challenges was presented was this concept of being able to monetize the work of the caregiver in a manner that would actually bring some earnings into a household and improve the outcome for the member and patient, and keep that person in place to be able to provide the care and the eyes that we need in the home.
And I'll just briefly talk about a little bit of our work in the last 5 to 10 years, which is to say we definitely want to have been always supporting partners who can try to help prevent chronic kidney disease. The National Kidney Foundation, educational opportunities, we have them, we partnered with them, because there's no question the best outcome for chronic diseases is to prevent them. And then if you have them, to slow the progression of them. Everybody wants to do that. That's a huge commitment. But the fact is, we have almost 600,000 people on some type of dialysis treatment today in the United States. And so one of the things that we've definitely worked on is to say, we have a lot of cultural diversity. We have a lot of socioeconomic diversity. How can we, at the local level, really help every patient to have the best quality of life if they have to have this kind of treatment, that they can. So we've done a lot of work on home therapies and transitional therapies to try to help people at least have as much control and choice and support from coaches, multidisciplinary care teams, patient communities that they can have. And I think that paying more attention to not just a cookie cutter treatment, but really working towards a treatment that's as personalized for the best outcome, best quality of life for patients who do have these chronic diseases they have to deal with is a requirement for us.
Great. Now we're going to move into taking a couple of questions from our audience. And I'm going to, not all of you have to answer every question. And so maybe just to get a couple of questions, I'll ask for volunteers. Let's start with one here. Let's see here. Here's one. Underserved communities have untouched potential. How can outreach to Latino communities promote awareness of opportunities that lead to better results? Who'd like to tackle that question?
Can you repeat it?
Sure. And I'm reading it as it has come in. Underserved communities have untouched potential. How can outreach to Latino communities promote awareness of opportunities that lead to better results?
I want to understand better the question, if that our underserved communities have a lot of potential, and how do we do outreach to better outcome, to get better outcomes? And if I'm interpreting it right, I love that question, actually. If I'm understanding it right, I think that outreach is a duty for our organizations. Outreach is not a favor. The time where we ask community to come to us is gone. We have to go to them. We have to put our chest inside there. We have to relocate, like Dr. Tice Wells was saying. We have to figure this out, because if they are not safe, nobody is safe. If there is not justice for them, there is no justice for anyone. So we owe it to them to outreach. Outreach needs to be done with creativity. I mean, from popular theater to door, to putting tables in the streets, to using every mechanism to let people know that their participation makes a difference. Not that you want to invite them for a service. You want to invite them to participate, to get involved, to understand that their voice matters, that they need to be counted. And that's the outreach. It's an outreach done with the purpose of including them and their voice, not just adding numbers to our services. But if they can connect with those services that have quality, that will help too. So I think that the untapped potential of the community is only tapped when you see that potential, when you see them as a partner, not just as a recipient of services, when you see them as a thinking person that should be in the thinking table, not just you in the thinking, they in the action. So that's where the untapped potential is tapped.
And
again, that's, the promotoras do a lot of that because they know it. They are from those communities and they know that they want to be taken into account.
Fantastic. And Reverend, did you want to comment as well real quick?
Yeah, and I think it needs to be multi-generational. You know, the best way to get to the family. Don't get to the abuela, don't get to mom or just dad, don't get to the child. Figure out a strategy that is multifaceted in addressing and reaching out to all the layers of a family, because if what you want to do is move the needle, you need to move the needle on everybody, because it's everybody coming together on the same page that's going to get you the most traction. So there's got to be a strategy that focuses not just on one person, but the unit of the family, right? In an effort to get everybody to buy in.
Fantastic.
Yeah, Rafael, outreach needs to be done by the right messenger at the right time, in the right place, in the right language. You know, and it's not just go and distribute flyers.
And as we can see, the playbook on outreach has to be tossed, right? We are in a new era, right? A digital era that is completely transforming how we engage communities multi-generationally. We have to be mobile. It's a whole new game. So I think that we've we have to be really thoughtful about this. I'm going to try to also paraphrase so I can get different themes as I'm looking at these questions come in. Here's another one. How might Latinx teens / younger adults educate their multi-generational households and families on COVID-19 prevention and recovery, economic recovery, and mental health?
That's a big one.
It's a big one.
That's it.
That's a big one, and I don't know if the Reverend wants to talk about it, but since we are in this all day, we have a team of youth promotores. So we have promotores that are 15 and 16. At this moment, we are also working with the school district, and they have the youth that are the youth ambassadors in the high school. We actually hire them with our COVID money so they could create their messages on social media. We train them. They are educating their families and they are creating messages that they are spreading and we are using. But again, we believe in the leadership capacity of young adults and even children. So the way we engage youth so they can engage their families is by seeing them as leaders of today, not just leaders of the future. Train them, give them the tools, let them be creative because if you are engaging them, let them lead. And they will do it. And they are doing a fantastic job in the messages that they are creating.
I would say you also need to find your cadre. You need your cadre that's going to champion your cause in a particular space, because the best communicator is a younger youth to a youth, because they will increase the following. And we have found in our engagement with particularly at the high school level. We could talk to a blue in the face, but the minute a young person says the same thing, they get a lot of traction. And they'll use social media, they'll use word of mouth, once they're committed and they're on the page, they are the best advocates for this situation.
Fantastic. Dr. Teiswells and Dr. Maddox, are there particular major health issues that you are seeing affecting children and teenagers?
Well, I'll jump in first if you don't mind. I think, certainly the things that we're seeing are the things that correlate with disadvantage, so with poverty and with challenges with built environment. So asthma, for instance, obesity are things that become top of mind. But also we need to keep in mind that as we're talking about these chronic illnesses, one of the things that happens in the Latinx community and population is the fact that we're seeing chronic diseases diagnosed much earlier, right? So, early onset of some of these chronic illnesses, and that is a quality, a characteristic that we have seen for years now, where you're dealing with teenagers, for instance, who are diagnosed with type 2 diabetes. And are then faced with the challenge of navigating dietary changes in the setting of school and home and whatever aftercare looks like and sports and those kinds of things. And so those are really key things. And it's impossible to have a complete conversation about this without acknowledging the fact that there are some things that happen in the built environment that we have got to start now thinking about. And I'm talking about coarse pollutants, for instance. You've got more kids that are living in inner city environments and breathing in things that kids in the suburbs are not inhaling. And while we in the medical community spent years trying to, deploy asthma programs to get moms to learn how to use the inhaler properly, right? The issue was not that, it was the air quality. And so that's an example of one of the places where advocacy and policy impacts that influence the external environment are going to be critical, or we'll be chasing ourselves, really not making much headway in terms of moving the needle.
Yeah, I agree fully with all of that. And I would say that certainly we are definitely seeing chronic diseases earlier related to obesity, just poor nutrition, unsafe environments. But also, I think that it's important to recognize that all of these built environment, social drivers that we've been talking about have true physiologic impacts for people. They change hormone levels, they change neurologic status. So the social issues have true physiologic impact, and I think that is a very big issue for our children. And not only do we see physiologic changes, but we certainly see mental health changes, all of which impact health outcomes in childhood and in adulthood. So.
Fantastic. I'm paraphrasing two different questions here to get this one because I think it's a fascinating one about, can one of you speak to action steps that could be taken to address social determinants of health in communities around the intersection of housing and poverty?
Yeah, at Esperanza, that like I was suggesting earlier, we understand that giving somebody a stable home has a series of impacts on the life of that individual. And we also understand that helping a person save money also has a correlation to more healthy outcomes in life. So we have always sought to provide stable housing and better access to jobs and savings programs in an effort to help families become more effective, more stable. Could you repeat the question?
Sure. I was paraphrasing it, so it may not come out the same way. Essentially, there was curiosity about addressing what action steps could be taken to address social determinants of health and figuring it out through addressing housing and poverty.
I might mention that just in the sort of traditional healthcare too, that research has looked at, like the Camden Coalition in Camden, New Jersey, looked at people who were high utilizers of the healthcare system, and were able to create an intervention that involved housing first. So certainly health coaching, but you access the state's housing vouchers to try to stabilize housing for people. And I think there's been some good research that has suggested that changes healthcare utilization and improves health outcomes significantly.
And there's been a number of studies that demonstrate the impact of just infusing money into a household. So the opportunity, for instance, to give a pregnant mom or someone with a chronic disease $100 a month or something like that has also been known to decrease emergency room utilization and hospitalization rates and that kind of thing, because there is something to be said for that financial toxicity that occurs in environments where you're constantly stressed about how you will move to your next step, and that the relief that comes. Dr. Maddox talked about the physiologic changes that occur. Those things that happen as a result of chronic stress are real, and it changes the internal milieu and changes how folks in communities like that respond, and sets them up, in fact, for worsened outcomes from their chronic diseases. So, speaking as a payer, I think as we think about innovative ways to solve this, we need to look at how we incentivize care and how we structure our reward program for our covered members, those kinds of things, as a way to again infuse money into some of those households as a way to combat the strain of poverty.
Rafael, and if I may, in Latino Health Access, we believe that needs do not change communities and needs do not improve communities. What improves communities is the strength of the person, is the talent of the person, is the strength of the community. That's what really makes our community better. So we see diseases and problems as doors that you can open and invite people to participate. So as we see housing and poverty as an entry door to deal with social determinants, what we need, the first steps are to include the people impacted by these issues, the people that are impacted by poverty and housing, and bring them to a table. They have an understanding of what is happening and why it's happening. Let's learn together, let's train together, and then there has to be a plan. For all of these inequities, we need to create plans that need to be funded. And in order to have a plan to address social determinants and be funded, we need power. And that is the word that sometimes healthcare is afraid to use, but we do need power. And without the power, we will not change policies. And this is not going to change. It's going to continue to be a medical, another vaccine that once it's done, the problem is gone. So we don't want that to happen. So we need to involve people. Let's use poverty and housing as two very complicated issues that go into many roots that have to do with historic disinvestment, discrimination, and racism. These are things that are not just old-fashioned. Well, don't mention that. Let's not talk about that. We need to talk about that. We are listening more and more the need to change the whole systemic racism that is excluding our people. So you want to address social determinants with housing? First, let's understand that people impacted by the lack of housing, people impacted by poverty have a problem but have the solution. Let's invite them to the table. Let's talk, let's make a plan, and let's fund that plan. And in order to fund that plan, we need power. Otherwise, the plan is going to be just paper. So let's organize. And at the end of the day, we just need to fund good, comprehensive strategies that will address that and more. And hopefully we will have a few minutes to talk about some ideas on that.
Well, actually, we are getting close to the end of our session, so I'm going to invite all of you to make a very brief closing comment. And I'll start with just Reverend Cortez, and then move to Dr. Wells, and then Dr. Bracho, and then go to Dr. Maddox. So, Reverend Cortez.
Yeah, at Esperanza, we've always looked at the community as a whole, and we've understood that it is the creation of institutions, right, that are responsive to the needs of the people we serve, that ultimately provide the best outcomes. So with that perspective, we've created schools, we've created a theater, we've created housing programs, we've created a series of interventions that we understand, when combined, provide for a safe community, right? A clean community, a more prosperous community, working with 300 businesses, small retail-related businesses in our community. It's the combination of all of that, the bringing together of all those resources that ultimately provides the greatest opportunities for the people in the barrio to access the kinds of services and the kinds of programs that could help them improve their lives. So ultimately, the way we see health is how do we find ways and models that can replicate that kind of comprehensive response in neighborhoods, so that we can see get some traction and improvement in the lives of people. And that's kind of been our philosophy for 30 years. And we're sticking with it. And so far we've done pretty good. So.
Thank you. Dr. Tice Wells.
Yes, thank you. This has been a wonderful conversation, and I was happy to leave my previous career and come to Guidewell Florida Blue, where we are a health solutions company. The idea being that it's more than what happens in the clinical experience. It really is all of the things that surround health, and we need to move towards solving some of those problems. With the recent social justice issues that have come to light in our country and really garnered so much attention, we have stepped further into that space, and as a large insurer in the state, have committed to doing what we can, and then acknowledging and recognizing what we can and partnering to fill those gaps. And what that means is we have to stand and say things about things that need to be spoken about. We need to be intentional in our partnerships and our collaboration to be sure that we are advancing best practices, right? All of us have this idea of the great program in the Panhandle or in the South or in the West or in the North. But those of us who have the ability, because we've got the reach or the funding or the connections, to duplicate those best practices and ensure that those programs get expanded so that all of the residents of our state have the ability to benefit from them, we need to do so. And we've committed to from a funding perspective, as well as to an internal restructuring perspective in terms of creating an equity alliance that is going to focus on some key issues. I love what Dr. Bracho said. It's more than dialogue, right? It really is developing a plan, being really intentional about it, and then being sure that the plan gets out of the folder, right, and gets toward implementation. That requires power and funding. And so it is the connections that I think we all have to make, public, private, healthcare, and nonprofit, together to get to solutions that will really sort of stand and work and continue to serve and meet the needs of our community residents, because it involves them, but also because it's not centered around whether or not we are physically present to oversee the work. And so thanks for the opportunity to be a part of such an incredible discussion. It's been great.
Thank you. Dr. Bracho.
Well, I want to first thank all the panelists for such a great conversation and thank you for the opportunity. I would start by saying that we need equity in data. That aggregated data is not helping with this fight. Aggregated data is what makes our communities invisible. So we have this great number for a county like Orange County that is rich, but then we ignore the pockets of poverty throughout the county. So we have to make our community visible. And then we need policies from Congress, that can somehow put a mandatory take into cities, so they should create plans for healthy communities with equity. And with that said, it's not just a plan, it's a comprehensive plan. That has to be equitable, with participation for multiple sectors, housing and education at the table, with multiple funding, with flexible funding, with community-driven, not just community representation with 2 people from the community and a bunch of institutions, but really community-driven, where it's an ongoing process of inclusion and it doesn't have always the same players. And at the same time, as complex as that sounds, we need to figure out how to address systemic racism, immigration reform, healthcare access, affordable housing, and yes, quality, timely care services for our people. And not to be overwhelmed for that. Just breathe and say, it has to be done. I don't have to do it all. I have to partner. I have to collaborate. I don't have to do what Dr. Ticewell does. I don't have to do what Reverend Cortez is doing or what Dr. Maddox is doing. I do my part. We do it together. The idea is not to say, I don't do that, but to say, who does that? And then involve those members in the collaborative.
Thank you so much. And Dr. Maddox.
So I think that's exactly right, this thing. So this has been a great discussion. I've greatly appreciated the opportunity to be part of it. And I do want to say that for me, this has been sort of an example of how we're transitioning from our traditional sick-focused healthcare to preventive, well kind of care. And we're still going to have our sick folks, and we're still going to have to keep caring for them in a very improving, ongoing way. But we want to continue more and more to prevent things and to lower risk. And so I think from a kidney disease perspective, we want to become a company that is taking care of people who have kidney conditions and taking care of people who are at risk for kidney conditions, all of those things. And that's going to require this collaboration. It's going to require change in legislation and regulation and reimbursement and benefits. And it's going to require partnerships and collaborations that have not been part of our traditional kind of sick care. So it's an exciting time, a great time of opportunity. And I think this panel is a good example of the broad spectrum of getting to that kind of well care that we want to provide.
Thank you all so much. Thank you for your service to your communities. Thank you for your service to your country and for the impossible task of trying to address every single social determinants of health on the panel and to try to tackle all of the various questions, because we all know it's just an impossible task, but I know you did an extraordinary job trying to do just that. But as we all know, in the Latino, the Latinx community, it is a resilient, beautiful, and powerful community, one that is beautiful and innovative and resilient. And we are just deeply grateful for this opportunity to have had this conversation with each of you and for all of you who attended. I want to thank our wonderful panelists, Dr. Kelly Tice-Wells, Dr. America Bracho, Dr. Dugan Maddox, and the Reverend Danny Cortez. Thank you all so much for joining us today, and thank all of you for joining us who have been watching from all over the country and all over the world. Please keep tweeting about the Health Summit at #CHCI Summit. We encourage you to attend our sessions tomorrow starting at 12 noon Eastern Time with our morning plenary titled Equitable Vaccine Development and Distribution, a very important discussion to have in light of the COVID-19 pandemic. If you know people who are interested in joining us for our closing plenary, it is not too late to register at chci.org. Once again, thank you for joining us. We look forward to seeing you tomorrow, and thank you so very much. Have a wonderful evening. Take care.